loved ones passes away, and the family asks you, should I tell my father, my mother, that my sister has passed away? Because she keeps asking. Have you all had this problem before?
พวกเรามีประสบการณ์เหมือนกับของคุณหมอคนนี้ถามไหม Yes, some of them yes.
That's a difficult question.
May I interrupt? This patient, he or she is advanced dementia or in which stage?
I just moderate dementia.
Okay.
So
still can understand.
Understand sometimes.
Okay. And still can remember all his, the family member, right?
I think
I have two cases just before I came. One, a couple, they both have dementia. One is 84, one is 83 or 81. And the wife, she is in hospital first. They both have comorbidity. The 81 years wife, she has severe, she has cancer, she had big operation. And then they didn't see each other for 3 or 4 months. Caregiver asked, her daughter asked me, should I tell my father? And then after, not too long after that, her husband came to hospital, admitted in ICU because of COPD exacerbation, and he also have dementia, severe dementia. He just passed away yesterday.
And the wife still didn't know?
Didn't know. And this is one case. Then the other guy, I have retired American guy. He married with Thai wife. He has one daughter who is 22 years old. He was admitted, he was bedridden for 5 years. What should I say? He doesn't, his leg was cut off, amputated both above knee. I don't know why. I don't know what happened. But he stayed with the caregiver that the daughter pay for him. And he was bedridden for 5 years. His life was on bed, watching English television. And he was put in hospital because he has grade 4 bed sore. He was intubated because of pneumonia, and then we did tracheostomy. Now he is on ventilator with tracheostomy. He had Parkinson before. His wife, he lived with his wife for 22 or more than that. His wife died 2 years ago. The daughter said she didn't tell him, her father, because she thought he wouldn't know, he wouldn't understand. Yeah, I try to communicate with this patient because no one knows how to communicate. No one knows what is he feeling right now. When I talk to him, he cried, and then end up we tell him, your wife, I don't know is this right or not, but we tell him, your wife is dead already, and she said she loved you very much. That's what she said.
Did she actually said that she loved him very much?
It is not me, but just my friend who did family meeting after she knew the information, because they live with each other, and he was alone for 2 years in hospital, 2 years at home without her. Then he was with caregiver.
And after you tell him that the wife has passed away, what is his response? You're not in the setting.
Because I asked friend yesterday what happened for the family meeting with his daughter. That's what she did. She told me that. That's my colleague who did family
what is the general feeling when you have patients like that? For yourself, what are your thoughts? Should you tell him that his loved one has died?
Yeah, I said I agree with her because he will feel lonely. And what happened? We lived together for more than 20 years. Now I'm alone.
Right.
I'm so lonely. I can't communicate. I can't speak Thai. I am in bed all the time, suffering from pain. No one give me pain medication, and I have no one come and talk to me.
And have he asked about his wife?
No one knows.
No. I mean, the nurse or the doctor who look after this patient, have he repetitive asking about his wife?
He cannot communicate. He has Parkinson. His arms always folded. He only can blink eyes. When I talk to him and I say, "Hi, I'm Dr. Namtip. I come here and would like to talk to you and try to help you and try to ask him what he needs. Like, does he feel pain sore because of grade 4, big pressure sore, and he just lie, do nothing because he can't move.
But he can communicate you with eye
I asked him to bring, yeah.
Uh-huh.
If you have pain, you bring your eyes. He brings.
So he actually didn't ask, right? For your case, he didn't ask. But for your patient, they asked. So what are your thoughts?
I think it's a doctor's obligation to tell him the truth. But how we tell him? Because if we keep lying, so patient live with and anxious and hope that next week or next month the loved one will come back. So I think we have to tell him that he or she is gone and not come back. But if you miss him, I can bring her a picture or something instead, so they can keep emotion connection.
Have you, in conclusion, have you tell,
Yeah.
have you informed? You have, right? You had. And then, to me, I think it is, I definitely agree with you, but I think the more important is how that you tell or inform them, right?
I think that it's very courageous because the fact that you are agonizing over it shows that you are worried about burdening the patient with this knowledge and will make them even sadder. I think that it takes. I think that it is important when the patients ask that we respond to them as truthfully as we can and as sensitively as we can. However, I'm very aware that because my patients suffer with illness that causes them to forget, they may forget what you have told them. Yeah. So what I tend to do is I watch the response. Yeah. So if they get very upset and they really get very depressed, I wonder then if they ask me again, what is the benefit of me repeating it? So sometimes I really I have to ask myself, if my patient keeps asking the daughter, and I keep telling him the daughter has died, and every time I tell him, he gets very, very depressed. It's hard on him, it's hard on the family to watch this. Subsequent to that, I try to distract him. Yeah. So that's how I do it. Yeah. I think it's very important to be honest and to tell the truth. But if they do forget and they keep asking, and their response every time you repeat the news to them is very difficult for them, then I question the benefit of having to repeat it to them again and again. Does that
I wonder if the demented patient can coping like a Cooper loss process, like sad, or bargaining, or maybe they accept eventually.
Sometimes I wonder whether they even understand. You must remember that when we have dementia, we may not understand. But I think that the sense of loss is very real. I don't really think that they, I mean, sometimes even normal people can't go through the grieving process. You know, it's like, so I think that the important thing is to check on the emotional well-being of your patients. You know, the information that you tell them. It's the same thing like, for instance, one of my patients' families asked me, should we tell Dad that he has cancer as well? That this is, you know, so I told her, if your father asks me, then I think that I should tell him, but I would tell him the same way I tell all my patients, as gently as I can, as truthfully, and I'll see whether he remembers. Yeah, so I will basically ask them what they know, see whether they, the reason behind the question, I will gently break it to them. I'll ask them how they feel with what I've told them. So I usually have these conversations with my patients in the mild to moderate phase. I rarely have them with my patients in the moderate to moderately severe. Because by that time they are unable to quite grasp so much complexity. Yeah. But did I answer both of your questions? You know, with regards to telling them?
Okay, I thank you. I check the patient emotion first, and maybe the detection is the best way to deal with them.
I think that also to watch their response. I mean, I think they will be sad, but I always wonder, will they remember? And
I mean, he or she may ask because they would like to ask, but nothing else behind the question. And then, this is what I thought, maybe right or wrong. But if I'm not wrong, according whatever you respond to him, if you mean that if he or she asks you, you tell them gently and most truthfully as much as possible, and also assess the response of the receiver. And then, okay, and then that day is passed, and then tomorrow we're going to see the patient again, and then he or she asks again, and then we have to repeat all this again, right? I think, yeah, it should be something like that, until one day, maybe he just asks automatically without any kind of meaning of that question. No one knows.
It's really, really challenging, looking after patients with dementia. They raise so many difficult questions that we have no clear answers to. But I think that it's just do your best. I think that, you know, it takes a lot of courage to be truthful. But the important thing is that when you tell them the truth, you're also trying to support them through it.
Yeah. May I ask, after you tell him the truth, what is his or her response?
Maybe the patient is sit still quite a while. Maybe patient crying a little bit, and some next week or that's another 2 weeks, patient asks me again, where is my daughter again? So I stopped. Told the patient that her daughter passed away. Just there are many persons that will take care of you instead. I think maybe the patient needs someone to take care of or love, so we can take care of you instead of the daughter.
And after you tell him something like that, what is his response? More calm, more relaxed, or the same?
The patient, just in my opinion, my patient is quite okay with this.
Had some more questions?
I would like to add some more points that sometimes the patient asks because he or she has unmet needs, which is like he has pain somewhere else, and in the past his daughter may be someone who massaged him. So first of all, look for the cause that made him ask you the same question, and then remove the cause. I have one patient that asked repetitively, oh, where is my husband? Which she already knew that her husband passed away for 10 years, and then she got UTI and got cognitive decline after discharge from the hospital. And after that, she came home and see the picture on the wall of her husband, and then she started repetitively asking, where's my husband, where's my husband, and take the picture frame with her and hold it at night and crying. And so her daughter came to the hospital and asked me what to do. She just couldn't steal the picture from her mom because she's crying all the time. So I suggest that she replace the picture smaller, smaller, and smaller. And then she did it, the daughter did it, and then finally I gave her the cognitive enhancer also, and her cognition improves a little bit. And then she just started to remember that her husband just passed away 10 years ago. So I removed the precipitating factor, which is a large picture, and then improve her cognition, and then everything gets better.
I was told I have to vacate this room by 7. It horrifies me to think that you think I will keep you here till 7. I hope I will do that. Yeah, so I'll just do a case study, and I want to share with you what are my nurses' thoughts about doing home care, if that's okay with all of you, okay? So let's just get refreshed by thinking through what we've learned so far. And I thought that this case study would be one of the better ones that we could share. So this is one of my patients. He was 78 years old. He used to work as a clerk in one of the big department stores in Singapore. And he developed dementia that when I started caring for him was already in the advanced stages of 7D. He was bedbound. He had all these vascular risk factors, but most importantly, he also suffered with chronic kidney disease, already end stage, with a EGFR of less than 15 for more than 2 years. And given his comorbidities, he was correctly advised that dialysis would benefit him. We know that in patients over the age of 70 with multiple comorbidities, does dialysis help them? No. It doesn't change their quality of life. It may not improve longevity like hemodialysis or renal replacement therapy, but certainly it doesn't improve quality of life. So rightfully, they decided to take the conservative approach. So he was referred to my PaLLintive home care program for advanced dementia. And when we visited him, he raised these issues. He noticed that his father was, sleeping in the day, and at night he would be the most active person in the world. When he was warded, the nurses handled it by restraining the father, because this gentleman, who is usually bedbound, somehow found the ability to nearly crawl. He had his bed, he had his legs swung over the curbside. So they thought he was trying to crawl out of bed, and they promptly do what we usually do, which is to tie him down. So he asked us, should he do the same? So be very careful of what you do in the hospitals, because the behavior continues even at home. So he asked whether we should do the same, because he knew that even though his family and his helper was very devoted, they couldn't stay up at night. So how would you proceed and manage?
คนไข้อายุ 78 ปีนะเคยเป็นเสมียนในบริษัทใหญ่โตก็โคมอร์บิดนะเขาก็เป็น Advanced Dementia แล้วก็อยู่ที่ Stage Fast 7D ไปเปิดเอาเองเนาะมัน describe อะไรแล้วก็มี Hypertension Hyperlipidemia เป็น ESKD เนื่องมาจากสาเหตุทั้งหมดนี้ทางซ้ายมือเนี่ยสรุปไม่ทำ dialysis ไม่มีประโยชน์ที่จะทำนะก็ conservative เขามีประเด็นอะไรก็คือกลางคืนไม่นอนกลางวันนอนแล้วก็แอคทีฟมากตอนกลางคืนพยาบาลก็เลยมัดไว้เพราะว่ากลัวตกเตียงญาติก็เลยบอกว่าแล้วกลับบ้านต้องมัดหรือเปล่ามัดเหมือนอยู่โรงพยาบาลเลยไหมอะไรอย่างเงี้ยพวกเราคิดว่าจะทำยังไงดี
You're very welcome because I gave you not very much information, so you're very welcome to do the approach of exam, and I'm here to share all the information that you need. You're absolutely right. We should have reorientated him in the hospital. Yeah, we should have tried, right? But we didn't. And now he's at home with you.
สรุปคนไข้ไม่ได้ถูก reorientate ตามที่หมอคนนี้แนะนำนะแล้วเขาก็ได้ออกกลับบ้านแล้วนะเราจะทำยังไง
So now he's at home with you. What would you do? The family's asking you, should we tie our father down?
มัดไหมจะบอกฮะ no
No. So then the family looks at you, so what should we do then?
เราจะให้ทำไงล่ะไม่ให้มัดแล้วให้ทำไงฮะ
My neighbor is getting this.
what
What?
oh no restraint and put him on the floor
Oh, he's very smart.
เอาเสื่อมาปูนะ
Actually, that's very clever.
อ่าฮะ
I should have thought of that.
อันนี้อาจารย์ได้โซลูชันใหม่
Okay, sleep on the floor.
then he will never ever fall
Actually, that's very
from the
clever.
bed
Sleep on the floor. I wish you had advised him. Okay, I wasn't that smart, so yeah, it's very compatible with Korean culture too.
yeah
Japanese as well, not very compatible with Singapore culture.
ทำได้อีกทำได้อีก
Sleep on the floor. That's actually very smart. Okay, so let's say that we can't sleep on the floor.
โอเคสมมุติว่าไม่สามารถให้นอนบนพื้นได้
This is super smart, by the way.
ฮะ
Okay, so we did do that.
โอเค
So guess who's sleeping on the floor? So, I have to tell you a joke. I had a patient once who would sleep on the bed, and then his daughter slept on the ground. One day he actually rolled over and landed on his daughter. So anyway, that's the okay. So get someone to sleep, yes, yes. And anything else? How would you approach this? Okay, remember, always ask yourself what is the cause. Okay, do another assessment, right? So
Yes, can you describe what kind of pattern that he have reversal of sleep?
wonderful. So interestingly enough, I went through the neuropsychiatric inventory, the questionnaire. Okay, this is called the NPIQ. Now you can read a list of these questionnaires in the articles that I gave you. It's a list of 12 questions. So in one of the questions, the issue of sleep came about, and he did share that his father wasn't sleeping well. So again, think back what is the cause of the behavior, right? The behavior is that, very good, so you're thinking of the ABC approach. So the behavior is that, oh, my dad would wake up and he's very active at night. So my nurse was very good. She asked him, can you describe the activity at night? Right, describe. So what he was trying to do is that he wasn't actually trying to get out of bed. He was actually restlessly moving in the bed. He just kept shifting his position. He wasn't trying to crawl out of bed. He was just moving out of bed.
itching
I'm quite good at as an actress.
yeah
Yeah, so you know what he was trying to do? Why do you think he was itchy? So he was actually doing this. He was actually doing this, you know, and he was doing it like that. So, and this was the behavior that the helper showed me.
okay
Yeah, so it's like, dad is doing this. So what is he was itchy.
yeah
So this was the behavior. Can I ask you, why is he itchy?
jaundice
Dry skin, very good. Dry skin, a lot of our elderly patients have dry skin.
urine
Wonderful. So this, you see, you all are so brilliant. You did the end stage.
okay
Renal
yes KD
failure. Okay, don't always think of the whole list of comorbidities. All right? It doesn't mean that you have cancer, you have cancer. You have nothing else. Right? It doesn't mean that if I have dementia, and nothing else. You look at all the list of problems that he had. He had end-stage renal failure, and this poor man had cirrhosis of his skin because we were giving him furosemide.
I see.
He was also having uremic
Mm.
itch. So he was actually doing this at night because he was itchy. He was super itchy. So I was asking them, this is very unusual. It means only at night. Oh no, Dr. Ham, he's also itchy in the day. He's actually not sleeping very well in the day. So actually, there was no sleep-wake reversal. He was just not asleep the whole day.
Yeah.
There was no sleep whatsoever. Very good. So the behavior, when we ask them to describe, is really not sleeping throughout the whole day, restlessly moving in the bed, and he was actually rubbing his skin because he was super itchy. And he was super itchy because we were making him itchy with the furosemide, drying him out like a twig. He looked like a prune. You know, in Chinese we have this thing called dried preserved prunes.
Yeah.
I don't know how you call it. In Hokkien we call it seng bui. Have you heard of that? It's really dried prunes. He looked like a prune. Very dry. And then
เหมือนบวย
he also had uremic skin, uremic itch.
Okay.
And that was why he was not sleeping well, he was itchy, and he was basically uncomfortable throughout the day. And that was why he was trying to get out of bed. He didn't realize he was trying to get out of bed. Okay, so now how do you manage?
May I translate?
Yes.
อาจารย์เขาถามหมอคนนี้ตอบว่าให้ประเมินคนไข้กลับไปที่ ABC ยังจำได้ใช่ไหมถาม caregiver หรือคนให้ข้อมูลแล้วว่า B ของเขาจริงๆคืออะไรกลางคืนที่ไม่นอนมันเป็นยังไงเขาก็จะบอกว่าจริงๆแล้วเขาไม่ได้เที่ยวเดินไปทั่วนะเวลาเราพูดว่ากลางคืนไม่นอนเราจะชอบนึกถึงคนเที่ยวเดินไปทั่วเขาก็บอกว่าไม่ได้เที่ยวเดินไปทั่วเพียงแต่อยู่บนเตียงแล้วก็ทำท่าสายไปสายมาแบบนั้นใช่ไหมแล้วพอเขาทำให้ดูปุ๊บเนี่ยหมอที่ถามก็นึกถึงว่าเขาน่าจะคันเพราะเขาน่าจะคันก็ไปดูภาพรวมใหญ่ก็เขาเป็น ESKD เพราะฉะนั้นเนี่ยมันก็เป็นยูริเมียได้ซึ่งทำให้คันใช่ไหมเพราะฉะนั้นตอนนี้ก็ถามต่อไปอีกถ้าเป็นอย่างนั้นจริงแสดงว่ามันต้องคันตลอดมันไม่ใช่กลางวันกลางคืนถามเพิ่มเติมก็ได้ความว่าเป็นอย่างนั้นจริงๆเพียงโดยส่วนตัวคิดว่ากลับไปที่ ABCD เนี่ยเป็นอะไรที่ทำให้เรานึกถึงโดยครอบคลุมมากที่สุดที่เราได้ B เราได้ A ใช่ไหมตอนนี้อาจารย์ถามต่อว่า C คืออะไร
So what's the C? Do we tie him down? No, because now we know that we have something to treat. Okay, so think non-pharmacological first. What can you do for someone with dry
ถ้า
skin?
เราไม่ถึงโอเค
apply. So what would you recommend? Emollient creams, right? So for uremic itch, we try emollient creams.
C ก็คือทาครีมก่อนยังไม่นึกถึงให้ยานะนึกถึงอย่างอื่นก่อนทาครีมก่อน
Okay, very good. Anything else? Cream. Yes. Now think back about. So this is. Remember, you are the jack of all trades, the master of all in palliative care.
Do he really need the furosemide?
Very good. Very dry as a twig, right? So we stop the furosemide. Thank you.
หยุดยาฟูรสมายที่ทำให้เขาแห้งเหมือนบวยบวยแห้งนะไม่ใช่บวยเปี
We
ยก
stopped because he wasn't drinking very much as well, you know. Yeah, so we stopped furosemide. Very good. Rationalizing your medications.
เอายามาดูเขาได้ยาอะไรที่มันไม่จำเป็นก็หยุด
So we really bought creams for them to bathe. We also put cream on him. We stopped the furosemide. We basically stopped the aspirin because he was bleeding into his skin. He was also very pale from the kidney failure. But he was still like happily at night.
The soap would be very mild soap. The soap for shower for take a bath.
Yeah,
The
so we
patient,
use.
it should be a very mild.
Yeah, so we use
type.
that for the patient as well. Yeah, in the morning. So we replaced it with a emulsifying soap. Yes. Still itchy.
ก็ยังคันอยู่ทำไง
Medication. Which one? gabapentin. Oh, you guys are so great. Thank you so much. First of all, I should make him sleep on the floor. How much do you start? Gabapentin. Remember that gabapentin is not kidney friendly, right? Yeah, so if you have renal impairment, you just have to be very careful. So how much do you all start for patients with
20. She said 20.
20, oh, you have 20 milligrams in Thailand. 100, yeah, that's how much I would start. Yeah, so someone who has end-stage kidney failure, I would never go more than maybe 300 milligrams a day. Yeah, okay? And actually, the wonderful thing about it is that we started on 100 milligrams. What other benefit does gabapentin have? It's also an adjuvant, right? For pain. Did you know that it is also recommended for patients with anxiety? Oh,
แต่ว่าเพนตินให้กับคนไข้ที่เป็น anxiety ได้ด้วย
anxiety. Yeah, so when we started 100 at night, we became the family's favorite team because he finally slept.
And then everyone can
He
rest.
finally stopped doing this.
Uh-huh.
And he was comfortable. So the other problems that came on, the fever, the infection, they did arise in the course of the illness. But it just shows you that we missed the diagnosis in the hospital. We missed the opportunity to do good. And actually, all we needed to ask the family was, tell me about the behavior again. Tell me what causes it.
Mm-hmm.
A, behavior B, A, and
C.
what the C is nearly crawled out of bed.
Yeah. ก็ตัวอย่างวันนี้ก็คือคนไข้ถูกมิสได้ตั้งแต่อยู่ในโรงพยาบาลด้วยเหตุอะไรไม่รู้กลับบ้านเนาะแล้วก็ด้วย ABC ง่ายๆนี่แหละแต่ถามให้ดีนะหาข้อมูลให้เยอะพอเราจะได้ที่มาใหม่
You all okay with that? Yes. I mean, it's not all cases are that, you know, I mean, this is not a simple case. I'm just simplifying it because we had to ask a lot of questions. But I think that it really shows, when I say I don't mean I. It's me and my wonderful team of nurses and my fellow doctors who really help as we work as a team to come to these conclusions for our patients. You know, and I think that's hopefully I convey that properly to all of you as well.
งานของอาจารย์ที่มาแลกเปลี่ยนเนี่ยอาจารย์แทนว่าเราฉันทำอะไรไอที่ว่าคือทีมของอาจารย์นะซึ่งมีพยาบาลแล้วก็หมอคนอื่นด้วย
Okay, so I'm going to go on a different path now. So this is where I'm going to focus on what it's like to be a home care nurse and doctor. So I'm going to switch roles now. I'm no longer a hospital doctor. I'm also a home care doctor as well. And I need to share with you why I do home care work. It's very difficult. The sun in Thailand and in Singapore is very hot. It's very, very tiring. So who are my home care nurses and doctors here?
ใครดูแลเป็นโฮมแคร์ด็อกเตอร์กับ
Can I
home
see
care
a
nurse?
show of hands who are my home care doctors and nurses?
ยกมือใครเป็นโฮมแคร์
Yeah. Let me tell you, these are true angels. These people who do this work every day. I only do it 1.5 days. It's so difficult. Those who do it every day, they have my full admiration because it's very, very tiring.
ทุกคนที่ยกมือโปรดรับทราบว่าทุกคนเป็นนางฟ้านะ
Really,
เป็น
really
เทวดา
well done, well done.
มันเป็นงานที่ยาก
So these slides are by my nurse, Sister Sylvia Lee. She actually shared them at the Asia Pacific Hospice Conference last year, and they were very well received. So I want to share them what it's like to actually the challenges of home care. All right. So this is really the island of Singapore. We're very small. I have had all of you. Have many of you come to Singapore before? It is no. Yes. You like it? You're all so kind, and of course you have to say you like it, right? But what we try to do is that even though we're very small, we try to be a little bit organized. So we try to actually organize into 3 regional clusters that cover the west of the island, the central part of the island, and the east of the island. And we try to ensure that patients are able to move from the hospital right into the community. And community in Singapore will mean the home or the nursing home or the hospice.
โอเคสิงคโปร์เนี่ยถึงแม้จะเป็นเกาะเล็กๆแต่เขาก็พยายามที่จะจัดให้มันเป็นระบบโดยการแบ่งออกเป็น3กลุ่มใหญ่ทางตะวันตกตรงกลางแล้วก็ตะวันออกแล้วก็เขาพยายามจัดระบบให้เกิดความมั่นใจว่าคนไข้ที่ป่วยอยู่ในโรงพยาบาลจะสามารถกลับไปยังชุมชนที่เขาอาศัยอยู่ได้
So this morning, before we started, you had a speech by your vice rector of the university, thinking about how to unite and create a model of care, right? That is continuous. So Singapore also shares that same vision. We're trying to provide what we call seamless. That means care that is no different from it. It flows. It's supposed to flow from the hospital. It's supposed to go into the home. That means that everything that you did very well at home in the hospital, you
in the home สิ่งที่เขาพยายามทำเนี่ยเอมก็คือให้การบริการการดูแลคนไข้จากโรงพยาบาลจนถึงบ้านเนี่ยเหมือนกันไม่มีรอยต่อระหว่างโรงพยาบาลกับบ้านนะทำอะไรได้ที่โรงพยาบาลต้องทำได้ที่บ้านด้วย
So 5.5 million people in Singapore.
สิงคโปร์มีคน 5.5 ล้านคน
So these are the community services that we have in Singapore. So I'm going to talk about my own program here. So we have a palliative home care that we call integrated. So Dover Park Home Care works with Tan Tock Seng Hospital as well as Dover Park Inpatient. I'll be showing you a little bit more tomorrow. And what we have in the home care is care not only for patients with cancer, but we look after patients with non-cancer as well. So program Dignity is for patients with dementia, and program Impact is for patients with kidney failure, heart failure, and lung failure. So we try to look after patients with end-stage disease, irrespective of whether it's cancer or not.
เขาก็จัดเป็น palliative home care ใช่ไหมก็จะมี3อันที่ชี้หายไปไหนไม่รู้ ก็จะมีDover Park Home Care เนี่ยก็จะทำงานกับทำท็อกซินของอาจารย์ก็แล้วก็ส่วนโปรแกรม Dignity will look after the
Dementia patients.
dementia right
Yes.
and here is the for the kidney correct the last one มันก็จะกดไปกดมาเดี๋ยวสไลด์เขาเลือก
Does it work?
Dover Park Home Care Program Dignity and Program Impact นะคะ
And basically we also have teams that go out into the nursing homes as well to look after patients with dementia. But we also go in.
คราวนี้เขาก็จะมีกลุ่มบุคลากรที่ลงไปที่ nursing home ซึ่งกลุ่มของอาจารย์เขาก็ลงไปช่วยดูแลด้วย
And some of the hospices, they also have what we call day care. So the patients come in the morning to exercise and do art therapy, music therapy, and in the afternoon they go home. So at least we give some respite to the caregivers.
โอเคใน hospice หลายๆแห่งในสิงคโปร์เนี่ยมีสิ่งที่เขาเรียกว่าเป็น day care service คนไข้มาตอนเช้ามาออกกำลังเล่นพบปะเพื่อนฝูงตอนเย็นกลับบ้าน
Recognize this map?
Yeah this is Concan
This is Concan. So Concan is shaped much nicer than Singapore. My island is 5.5 million. I just found out that for your beautiful province is 114,000 people.
114,000
Your population, is that correct?
I'm not sure 3 million
Whole province? Oh, I'm totally wrong. So 3 million. So I wanted to find out how do you all function in Concan?
เราทำยังไงเนี่ยขอนแก่นระบบของเรา So Sylvia will be the one who answer this question
We have
large hospitals in the city area. So Sinakrik by hospital, and the other is the Khon Provincial Hospital.
Right.
So if the patient discharged from our program, then we do our own home care visit. But apart from that, all the rest, and nearly the rest of the city Khon responsible by the Khon Hospital, which they have a home care team. They call long-term COC. Continuity care.
Oh, it's the same
Center.
as ours. It's a community and continuing care. Oh, we have a
And-
department like that too.
Right.
Yes. And is your service 24 hours a day, 7 days a week for home care?
For telephone call, 24 hours a day. But at night we could not go to do home visit.
Oh.
But if they have emergency, we are going to tell the patient to go to the ER, and then we
Oh.
help coordinate
Right.
with the doctor who's at ER. And then outside the city of Khon Kaen, in the city area, we have about, I think, 300,000 population.
Ah, yes.
And the rest they have divided into district. And each district, they have district hospital where they have a palliative care unit program.
Oh, wow.
Which they give service palliative care for their own district.
Oh. So are the different districts represented here today?
Yes.
I think
ทุก
mostly
โรงพ
are
ยาบาล
from
มาเปล่า
provincial hospital.
Wow. So the thing is that I think that's wonderful, and I think that's so great that you are doing this. In Singapore, because we don't have district hospitals, because we're so small,
Yeah.
we're just a red dot. Yeah. So what we try to do is that, and the ministry also doesn't like patients to go back to the emergency room unnecessarily. Yeah, if you come to the emergency room, your waiting time is 18 hours.
Okay.
Very long. So what we do is that our home service is 24 hours a day, 7 days a week.
ที่ประเทศอาจารย์เนี่ยถึงแม้ว่าเกาะเล็กนะแต่ว่าเขาก็มีนโยบายที่ไม่ต้องการคนไข้เนี่ยมาที่ฉุกเฉินเพราะว่าเวลาที่ต้องรอที่ฉุกเฉินนานมากอาจารย์เขาให้ตัวเลขว่า18 ชั่วโมงซึ่งไม่น่าเชื่อนะเพียงผลที่สุดเนี่ยก็คือนโยบายระดับประเทศของเขาก็คือว่าให้คนเนี่ยรักษาตัวอยู่ที่บ้านแล้วก็เลยต้องการให้ Home Care Service เนี่ยสามารถให้24 ชั่วโมง 7 วันต่ออาทิตย์สรุปไม่มีวันหยุด
So if let's say that it is our patient at home, and our patient at home is not well during office hours, they can come straight to the hospital. They do not need to go through the emergency room.
โอเค เพราะฉะนั้นคนไข้ที่ดูแลรักษาตัวอยู่ที่บ้านแล้วถ้าเกิดเหตุบางอย่างที่คิดว่ามีความจำเป็นต้องไปโรงพยาบาลเขาจะไม่ไปที่ฉุกเฉินเขาจะตรงมาที่หน่วย palliative ของอาจารย์เขาเลย
Yeah, so that's how this is why we call it an integrated service. So if the patient's at home, and we know that they're very ill, and coming to the hospital is not going to help them. So for instance, my patients with dementia at home, if we know that they are dying and the families can't cope, is coming back to the hospital the best option? No,
No.
right? So, but the families can't cope, so what do?
we have to go there to help
We go there to help. So if patients want to die at home, we're there. But some of our families feel they don't really want their loved ones to die at home. So in that case, we then move them into the hospice. So this is why we call it integrated. So we have a system in Singapore where the hospital here will work with the home care team as well as the hospice. At the center of it is your patient. So it's a bi-communication both ways. So we communicate both ways with the teams. So we just move in a circle around the patient. So this is why we call it an integrated care. So if we pick up from the home that something is wrong with the patient and that they need care that does not suit the hospital, we go into the hospice. So what we're trying to do is what we call right site care.
Wow. Okay.
That means that we go to the correct place where the patient will have their needs met.
อันนี้เป็นระบบของสิงคโปร์นะสรุปแล้วเนี่ยก็คือว่าจะมีการทำงานร่วมกันระหว่างโรงพยาบาลแล้วก็โฮมแคร์ทีมแล้วก็ฮอสปิสพวกนี้ทั้ง3ส่วนนี้จะทำงานก็คือจะสื่อสารกันนะโดยที่เอาประโยชน์ของคนไข้อยู่ตรงกลางถ้าคนไข้ป่วยอยู่ที่บ้านแล้วถ้าคนไข้มีความจำเป็นอะไรบางอย่างที่เดือดร้อนน่ะแล้วจำเป็นต้องเข้าโรงพยาบาลเนี่ยเขาอาจจะต้องดูว่าอาจจะจำเป็นต้องมาโรงพยาบาลไหมหรือว่าไปเข้าที่ฮอสปิสดีนะซึ่งตรงนี้เนี่ยหรืออาจจะไม่ต้องไปไหนเลยอยู่นั่นแหละเราจะส่งทีมไปที่บ้านของคุณเองเพียงทั้งหมดนี้เขาเลยเรียกมันว่าเป็น integrated system คือการทำงานที่ประสานกันนะแล้วเขาก็เรียกให้ชัดเจนมากขึ้นอีกว่าเป็น right side care side คำนี้แปลว่าตำแหน่งให้ตำแหน่งก็คือจะอยู่ตรงจุดไหนอะที่เหมาะกับคนไข้วางเขาให้อยู่ในตำแหน่งที่เหมาะเป็นการเซอร์วิสแบบนั้น
But this means that your doctors and nurses are talking to each other. But it doesn't mean that I work here and I send the patient home. Goodbye. I still talk. They talk to me. And even if they go to the hospice, we're still talking.
Okay. And have you have to go to the hospice to do to take care of the patients?
So currently, I work in the hospital and the home care. Hospice is I no longer work there. It's just there's only 5 days in the week. So yeah, so it's a bit too much for me. But the hospice is where I used to work in the hospital and hospice. So the things that I know my colleagues very well. And oftentimes when my patients are in the hospice, because our headquarters are there, we go and visit the patients there as well.
Okay.
Does that make sense?
Yep. To me, yes. But I'm not sure for the other. สรุปทั้ง3หน่วยเนี่ยเขาจะต้องสื่อสารกันนะคะแล้วก็ถามว่าอาจารย์เขาต้องลงไปดูแลที่ hospice ไหมเพราะณปัจจุบันเขาทำที่ hospital กับทำงานร่วมกับ home care team เขาไม่ได้ไปที่ hospice แต่ที่ hospice ก็มีเพื่อนร่วมงาน colleague ของเขาอะทำงานอยู่ที่นั่น so in the hospice setting they also have nurse and doctor
Yes,
right
yes. So because we are attached to the hospital and the home care team, it's a very, very coordinated effort to look after the patient.
Yeah, and every hospice in your country is a public sector or the private?
There are some private ones, but mostly the 4 major ones are public. But Dover Park is currently the only one that is attached to a hospital.
ในโฮมแคร์ทั้งหลายแหล่เนี่ยโดเวอร์พาร์คเป็นอันเดียวที่ทำงานร่วมกันกับโรงพยาบาลแล้วก็โฮมแคร์ฮอสปิสส่วนใหญ่ในสิงคโปร์เนี่ยจะเป็นของรัฐนะน้อยมากที่เป็นเอกชน
So I just wanted to share with you what we do slightly differently from Thailand. And basically, our patients are actually able to fulfill their wish to die at home. So this is a study that was done several years ago in Singapore, and they surveyed Singaporeans, and they found that 77% of Singaporeans wanted to die at home. I actually couldn't find a study in Thailand. There's never been, has there been a survey done of the?
It is an informal survey.
Was there an
right?
informal survey? What, do you know the percentage of Thais who would like to spend their last days at home?
I'm not sure if there's a survey report or something, but I think there's one survey from Sri Lanka where they do survey for the elderly who come to attend the geriatric clinic to ask them where they want to die. But that group of elderly, they are in Bangkok. So in Bangkok, you could not die at home. There is no home care for dying patient. So most patients want to die in the hospital. But in our ordinary work, in the northeast of Thailand, I would say that 90% want to die at home. And for my hospital, Sinakrin, 70% die at home. We could send the patient
70%
to die at home.
That's amazing.
But if it's the provincial hospital like Mahasarakam or Roy Ed, I would say that 90% of them die at home.
And that's what your patients want.
ถ้าหมอบอก 90% ถูกไหม 90% provincial hospital.
Is that what your patients want?
เป็นสิ่งที่คนไข้ต้องการหรือว่าเราผลักดันให้เขากลับไปตายบ้าง
No, they want to die at home.
In Bangkok, you have no choice.
This is the culture of the people here.
Wonderful. Okay, so the thing is that a lot of now if you were in Hong Kong, no one wants to die at home. You know why? Not the value of the house comes down when you die at home.
Okay. It will possess by spirit.
Yes. So every culture is different. Yeah. Because Hong Kong, you think that, and in Hong Kong, people Chinese like you, Singapore, mostly Chinese, not the same. Yeah. So the thing is that, what are the factors? So you've mentioned some of the factors that allow our patients to die at home. In Bangkok, every time I'm in Bangkok, I ask myself, how would I do home care in this province? I think I'll die in the traffic first.
And I go to the hospital in time.
I can't get to the patient in time. Sometimes when I'm looking after patients and they call me for emergencies, we have to actually speed there. I tell my families, I'll be there in half an hour. They always tell me it's the longest half hour of their lives. Because they're like, where's the pain? Where are the doctors? Where are the nurses? So long. Singaporeans are not patient like the Thais. So this was a study done by Irene Higginson with Dr. Barbara Gomez. They did a systematic review and they really looked at the factors that support patients dying at home. And I thought you might want to know that it relates to having good family support. That means that patients who live with their relatives are more likely to die at home. So if they have family support, they live with their relatives, they are more likely to be able to succeed in spending their last days at home. If they've stated their preferences, if they have a home care service and they use it, they are more likely to stay at home. Interestingly enough, if their function is very poor, they're also more likely to stay at home. So these are some of the factors that lead to patients fulfilling their wish to spend their last days at home.
โอเค อันนี้เป็นงานวิจัยของบาร์บาร่าโกมส์นะ แล้วก็เพื่อนเขาฮิกกินสันเขาพยายามหาว่าอะไรเป็นปัจจัยที่สนับสนุนให้คนไข้เสียชีวิตที่บ้าน แล้วก็เสียชีวิตที่บ้านได้สำเร็จนะ พบว่าหากเขาอยู่ร่วม คือเป็นครอบครัวที่ไม่ได้อยู่โดดเดี่ยวมีญาติเยิดรวมอยู่ด้วยเนี่ย โอกาสจะเสียชีวิตที่บ้านเนี่ยมีความเป็นไปได้คือสำเร็จเนี่ยสูง หรือเป็นความต้องการของคนไข้โอกาสก็จะมีความสำเร็จเนี่ยสูง หรือมี functional status น้อยก็จะมีโอกาสเสียชีวิตที่บ้านสูง อันนี้ก็เป็นปัจจัยจากการศึกษานี้ May I ask what is this historical trends?
Historical trends relate to the country's culture. Okay. So, for instance, in Hong Kong, hardly anyone dies at home. So that trend has persisted. Yeah, in Singapore, we are a bit of a mix. We do have a balance of people who want to die at home and those who don't want to die at home. More towards wanting to die at home. But in Thailand, of course, the culture is very different as well. So that's the historical trends, cultural trends really. Okay.
อันสุดท้ายนี่ที่ถามว่า historical trends นี่คืออะไรจริงๆมันคือเรื่อง culture ว่าวัฒนธรรมเป็นอย่างไร เช่น คนจีนจะไม่ชอบให้ในบ้านมีใครไม่อยากให้มีคนตายที่บ้านกลัววิญญาณจะอยู่ในนั้นอะไรอย่างเงี้ยบ้านนี้ก็จะแบบเป็นที่น่ากลัวอะไรอย่างเงี้ยอันนี้ก็เป็นความเชื่อ
I wanted to show you some of our own work in Singapore. So Singapore, the largest home care is the Hospice Care Association, and they looked back at over 19,000 patients. That's amazing, right? So they found that patients who were more likely to die at home were those who were female, older, those who live with a caregiver, again, those who have a non-cancer diagnosis, better supported. That means that nurses and doctors, so maybe when they feel more supported by doctor and nurses visits, they feel more confident remaining at home. Shorter duration of home hospice, so that means that the service that the team gives them is not so long, and they were fewer episodes of hospitalization. So they found that these were the factors that were associated with dying at home. So again, it suggests that if you have support from a caregiver, that you have support from a home care team, you are more likely to stay at home.
So, Aline, can I ask the issue of non-cancer diagnosis? Is that because they could not get access to hospice service?
Actually, no, Dr. Srivian. We access patients with non-cancer have equal access to inpatient hospice. But it's the same outcomes with Barbara Gomez as well. Non-solid tumors, decreased odds of. Hers was decreased odds of home death. But for ours, it was non-cancer.
It's opposite, right?
It's opposite, sorry, yeah. But we do have equal access for them in hospice. But you may be right to say that the awareness may not be there.
So, may I ask, this is, you try to see the association of...
No, this was just a descriptive study. There was no associations here.
Oh, and then you found that the one who died at home have to have all these.
They were more likely. So
to have
in this study, I wasn't involved in this study, but they found that when they looked at those who were more likely to die at home, they were more likely to be female, more likely to be older. There was no associations here. Yeah, none here. But in a study that we did in our own home care, so this is where I was involved. I really, the study that was done by HCA was a little bit descriptive. It didn't really shed more information than we already knew this. So what we wanted to do...
May I translate this first? อันนี้นะเป็นงานที่ทำโดย SCA นะเขาก็ทำในคนไข้ 19,000 คนโดยประมาณว่าคนไข้ที่เสียชีวิตที่บ้านเนี่ยมักมีคุณลักษณะอย่างไรก็พบว่าส่วนใหญ่จะเป็นผู้หญิงส่วนใหญ่อายุเยอะส่วนใหญ่จะมี caregiver ส่วนใหญ่จะเป็น non cancer มีหมอแล้วก็พยาบาลไปเยี่ยมที่บ้านเรื่อยๆก็เลยทำให้เขารู้สึกอันนี้คิดเองว่าเขารู้สึกอุ่นใจหรือเชื่อมั่นว่าเขาอยู่ที่บ้านได้ถ้าเขาต้องไปอยู่ใน home hospice เนี่ยเขาอยู่ในช่วงระยะเวลาสั้นๆและอีกอันนี้ก็คือมีเหตุฉุกเฉินเข้าโรงพยาบาลน้อยอันนี้คือสิ่งที่เขาพบนะในการวิจัยนี้ซึ่งอาจารย์เขาไม่ได้ร่วมทำสไลด์ถัดไปคืองานวิจัยที่อาจารย์เขามีโอกาสร่วมทำ yes so next slide you get involved
so this is actually from Dover Park Home Care. So we wanted to find out about what we call unplanned hospital admissions, or UHA. So for these patients, we call it unplanned when they actually told us that they do not want to go back to the hospital, and yet they went back. So this was a study to try to find out why did they change their decision.
การศึกษานี้นะเขาศึกษาในคนไข้ที่บอกแจ้งความประสงค์ว่าไม่ต้องการเข้าโรงพยาบาลแต่เกิดอะไรขึ้นเขาจึงกลับเข้าโรงพยาบาลคือทำไมถึงเปลี่ยนใจคือเขาได้บอกชัดเจนว่าเขาจะไม่เข้าโรงพยาบาลเขาจะไม่เสียชีวิตที่โรงพยาบาลแต่เกิดอะไรขึ้นเขาจึงได้มาเข้าโรงพยาบาล
And we found out that the older the patient, the lower the socioeconomic group. That means that the poorer that they are, they're not very wealthy. That if they have an elderly spouse as a caregiver, because they're quite elderly, so their spouses, their husbands and their wives are also quite elderly.
Yeah.
We also found that they were more likely to be suffering from a gastrointestinal or lung cancer. And very interestingly enough, or not surprisingly, most of them had these symptoms that caused them to go back to the hospital. We found when we look back at the care needs that 2 weeks before they were admitted, that they needed to contact the home care team very often. They did not discuss their care plans. So they didn't communicate with the team what they wanted to do when they got very sick. So team not very good. We didn't discuss it with them. And interestingly enough, the person who reversed the decision to go to the hospital was the same one who didn't want to go. Are you surprised that most of the unplanned admissions occurred after office hours? That means that the team was, although we had emergency contacts, they swooped back to the emergency room.
It means that if they decide to go in the office hour, maybe not success to
That means that
hospitalize.
during office hours, they were able to. I think that a lot of them, because we realized that a lot of them didn't know that the doctors would visit after office hours.
I see.
Yeah, they only thought that the doctors would visit during office hours. So a lot of them didn't call us after office hours.
We also look into our data, but for only just 1 year only, last year. We found that we admit that in our patient, the most common cause is caregiver burden. And later on, the patient who don't decide their advanced care plan yet. I think this is the two most common factor. And since we have developed our home care program with only just one nurse who conduct that program, it means that she have use more time with the patient when they do home visit. So in that group, there is few readmission.
Have you published that?
No, because we only just have
Pre and post.
20 readmission. I think
Never
I'm going
mind.
to do more
Just show it.
retrospective.
Yeah, that's wonderful. So it shows that, when you just do a simple nursing-led intervention, it made all the difference, right? I mean, what is the common theme in all the studies that I've shown you? Home care matters. If you have home care, you are able to perhaps reduce unnecessary visits back to the hospital, because we know that going back to the hospital may not actually improve your quality, it may not improve the quantity of your life. But how do I say that in Thai? Going back to the hospital may not increase your quantity of life, it may not improve your quality of life.
อาจารย์ก็บอกว่าประโยคที่เราต้องสื่อสารไว้ให้ชัดเจนเนี่ยคือต้องบอกกับครอบครัวและคนไข้ว่าการที่คุณมาเข้าโรงพยาบาลใหม่มารีแอดมิทเนี่ยมันไม่ทำให้คุณภาพชีวิตคุณดีขึ้นไม่ว่าในแง่คุณภาพหรือในแง่ปริมาณคือจะอยู่ได้นานขึ้นไม่อันนี้มันเป็นความเข้าใจผิดอันนี้เราต้องสื่อสารออกไปให้ชัดเจน but I just wonder according to the previous slide you said that if they have the visit from the doctor and nurse quite often they will feel quite confident to die at home. And for the next slide, all these group they also have that service, right? The doctor and nurse also going to visit them quite often. They still want to readmit to the hospital.
Correct.
Okay.
So I think that in this study, the outcome is, this is not about dying at home, but the other study was about dying at home. Our study was trying to understand. This was to understand why patients change their mind.
Okay.
When they tell us, actually, doctor, I don't want to go back to the hospital. No, tell my nurse, I don't want to go back to the hospital. But they do. Why? Because we realized that they have symptoms that we didn't address properly. That they were not. Yes, they are caregivers, like Dr. Sri Vieng said, were tired and didn't know what to do. That they basically didn't seem to have very much support financially. Yeah. So some of my patients who remain at home actually hire private nurses to help them remain at home. These patients have a hard time existing. Who has money to hire a private nurse? So these are some of the factors that we had to reflect on as a team. So we had to ask ourselves, how can we do better? So what we have done is that we have made more of an effort to reach out to the elderly Chinese community who only live with their spouses. So now what we do is that we actually ensure that when we go and visit them, that we update them in the same language, and we talk to their children. We try to do an advanced care plan with them. And we try to make sure they know they can contact us after office hours.
โอเคการวิจัยอันนี้นะอาจารย์เขาต้องการหาว่าทำไมคนไข้จึงเปลี่ยนใจกลับมาเข้าโรงพยาบาลใหม่ทั้งที่ก่อนหน้านั้นยืนยันนั่งยันว่ายังไงก็ไม่กลับไปโรงพยาบาลอีกครั้งเพราะฉะนั้นเขาต้องการดูว่าอะไรทำให้เขาเปลี่ยนใจผลที่สุดก็คือสิ่งที่เขาพบนะก็มักจะเป็นชาวจีนที่อายุเยอะแล้วก็ค่อนข้างฐานะไม่ดีคนที่ให้การดูแลรักษาแคร์กิฟเวอร์ที่บ้านก็คือคู่ครองนะแล้วก็โรคที่เขามักจะเป็นก็มักจะเป็น GI หรือว่าเป็น lung cancer มักจะมีอาการไม่สุขสบายที่คุมไม่ได้ดีเช่นปวดแล้วก็ในระหว่าง2 อาทิตย์เนี่ยโทรหาขอความช่วยเหลือจากทีมสุขภาพเนี่ยบ่อยๆแล้วก็ไม่ได้ทำ advanced care plan ล่วงหน้าแล้วก็คนที่ตัดสินใจคนที่เปลี่ยนใจว่าจะกลับมาโรงพยาบาลก็คือตัวคนไข้เองที่ตอนแรกบอกว่าฉันจะไม่เข้านะแล้วก็เขามักจะกลับมาเข้าโรงพยาบาลตอนหลังจากชั่วโมงทำงานอันนี้คือสิ่งที่อาจารย์เขาพบเพราะฉะนั้นเขาทำยังไงพอผลจากการวิจัยนี้ออกมาสิ่งที่เขาทำตอนนี้ก็คือว่าเขาให้ความสำคัญเจาะลงไปในกลุ่มประชากรที่ยากจนและเป็นคนจีนและก็มีคู่ครองเป็น caregiver แล้วก็ไปให้ความมั่นใจว่าพวกเราทีมสุขภาพจะมาดูแลคุณทุกบ่อยคุณอย่าได้วิตกกังวลแล้วอาจารย์เขาคาดว่าหากเขาทำแบบนี้การเปลี่ยนใจใหม่ที่จะกลับเข้ามาแอดมิดใหม่น่าจะลดลง
So that's why we do research so that we can do better.
อันนี้เป็นเหตุผลว่าถ้าเมื่อไหร่เรารวบรวมข้อมูลแล้วเราทำวิจัยมาหรือไม่ต้อง publish ก็ได้นะแค่รวบรวมข้อมูลเราจะเห็นทิศทางบางอย่างแล้วเราจะเอาไปแก้ไขว่าเราควรจะเดินทางไหนดีเพื่อทำให้การเซอร์วิสของเราดีขึ้น
So for us, we basically ask ourselves, is dying at home something that we can achieve for all our patients who want it? So it means that we need to get more palliative services, which is why you are trying to develop and upgrade the palliative care services in all your hospitals and all your districts. So we need more palliative care, and we just need to make sure that if we really want to do it, we need more caregiver support, and we need to ensure that home care is affordable for all patients in Singapore as well as in Thailand.
So โอเคอาจารย์บอกว่าเราต้องตั้งคำถามตัวเองว่าการเสียชีวิตที่บ้านเกิดขึ้นได้จริงไหมคำตอบคือจริงถ้าเราทำให้ PaLLitive Care เนี่ยเป็นที่รู้จักมากกว่านี้คนรู้จักมากกว่านี้และมีการเซอร์วิสเรื่อง PaLLitive Care ได้จริงการเสียชีวิตที่บ้านก็จะมีความเป็นจริงอีกอันหนึ่งที่ทำให้ PaLLitive การเสียชีวิตที่บ้านเป็นจริงเนี่ยก็คือเรื่องของ caregiver ต้องได้รับการสนับสนุนนะช่วยเหลืออย่างดีอะไรอย่างเงี้ยก็จะทำให้เนี่ยเป็นไปได้ที่จะเสียชีวิตที่บ้าน
So the question we have is that because in Thailand most of our patients die at home, but this may not be always possible. Sometimes our patients have symptom needs that are quite challenging. So although some of my patients want to remain at home, sometimes I have to be the bad person. I have to tell the families that you are clearly tired. Your loved one needs me to be around most of the time. We may need to come back to the hospice. Now, so I think that what we need to emphasize is that although it is preferred, it may not be something that we can actually do practically for all our patients who want it. And don't be discouraged. Okay, don't use this as a standard of care. We want to advocate for home care, but we should not put pressure on our families. we must recognize that some of our patients, they might want to stay at home, but when they are actually dying, that decision may change. And as we have reflected, the road is not always straight, but whatever happens, we are with them. And we will support them, be it at home, in the hospital. Some of my patients call me up in the hospital and say, Dr. Ham, I'm so sorry. I had to admit my father to the hospital, even though we agreed we didn't want. And I always ask them, why are you sorry? It's not about me. It's about your dad, it's about your mom. Is your mom okay? Where is she? Let me go and see how she is. That should be our standard of care, right?
Right.
It's about, who is it about? Our patients.
โอเคการเสียชีวิตที่บ้านเนี่ยเราอย่าเข้าใจผิดว่ามันเป็น gold standard เพราะว่ามันมีปัจจัยมากมายที่จะทำให้การเสียชีวิตที่บ้านเนี่ยเป็นไปได้หรือไม่นะเพราะว่าจริงๆคนทุกคนถ้าเราไปถามเขาอาจจะบอกว่าเขาอยากจะเสียชีวิตที่บ้านแต่เนื่องมาจากโรคที่เขาเป็นหรืออาการไม่สุขสบายที่เขาเป็นขนาดนั้นนะมันเป็นไปไม่ได้ที่เขาจะไปเสียชีวิตที่บ้านเขาต้องการการช่วยเหลือจากแพทย์หรืออุปกรณ์บางอย่างที่ทำให้เขายังไงก็ต้องอยู่ที่โรงพยาบาลเพราะฉะนั้นอย่าไปทึกทักเอาเองอะแล้วก็การเสียชีวิตของคนไข้ไม่ว่าจะเป็นที่บ้านหรือที่โฮมแคร์หรือที่ฮอสปิสหรืออะไรเนี่ยหรือที่โรงพยาบาลมันก็เป็นที่ที่ดีที่สุดอะสำหรับการเสียชีวิตณขณะนั้นเพราะว่าปัจจัยมันไม่เหมือนกันเราก็เพียงแต่ไปอยู่ด้วยถ้าเขาร้องขอหรือญาติร้องขอโทรมาเนี่ยต้องขอโทษคุณหมอด้วยนะที่เอาพ่อกลับมาแอดมิดทั้งที่รับปากว่าจะไม่สิ่งที่อาจารย์เขาทำก็คือไม่มีความจำเป็นจะต้องขอโทษมันเป็นเรื่องที่มันเกิดขึ้นได้คุณพ่อคุณอยู่ที่ไหนเดี๋ยวหมอจะไปช่วยดูนะมันต้องเป็นอย่างนั้นค่ะ
So the thing is that it's all about communication, and it's very important that we remember that whether at home or in an institution, this is a hospital bed, this is our Dover Park, and this is RCC, a single bed. It's not about where our patients die that is important. It's really about the fact that living until you die and accessing good enough care in whatever bed you are in. It means that wherever you are, our greatest goal is to ensure that we offer peace to the dying and care for the living.
อันนี้ก็จะเป็นรูปของเตียงในสถานพยาบาลต่างๆในระดับโรงพยาบาลในฮอสปิสหรือในอะไรก็แล้วแต่อาจารย์บอกว่าไม่ว่าเตียงไหนที่คุณนอนตายอ่ะมันไม่มีความสำคัญมันอยู่ตรงที่ว่าคุณควรมีชีวิตอยู่จนกระทั่งคุณตายนะ living until you die นะแล้วก็ในระหว่างที่มีชีวิตอยู่จนกระทั่งตายเนี่ยคุณควรได้มีโอกาสเข้าถึงการบริการสุขภาพที่ดี
So palliative care is not about dying, right? It's
No.
about living.
Yep. ตอนนี้เราต้องเปลี่ยนแนวคิดนะ palliative care มันไม่ใช่เรื่องของการตายแต่ต้องเป็นเรื่องของการมีชีวิตอยู่อย่างมีคุณภาพจนกว่าจะตาย
So this is what we do in palliative care. We do this amazing whole slew of things. All right? And we do this so that at the end of the day, our patients can have the best outcome. All right?
อันนี้คือการให้บริการ palliative care ที่ comprehensive นะตัวเองก็เห็นด้วยว่าอย่างนั้นทำอะไรบ้างทำกล่องต่างๆเนี่ยอ่านเอาเองหมดนี้ทำแล้วคนไข้ก็เป็นไปได้ที่จะได้รับการดูแลที่ดีที่สุดที่เป็นไปได้สำหรับเขาและในที่เขาต้องการ
So if you think about it, you all do this. You all do very good symptom management. You support emotionally. You support socially. You assess who they are, where they are. You help to support them financially. You offer therapy, physical, occupational. You have your volunteer team. You prepare them for dying. You support their loved ones. You educate them. And you talk all the way.
ก็ทำเยอะแยะเนาะอย่างที่พวกเราพอมีพื้นฐานแล้วอะ symptom psycho social spiritual เงินทองคนให้การช่วยเหลือเตรียมสำหรับจะเสียชีวิตทำ advanced care plan ต้อง collaborate ใครไหมแล้วถ้าตายไปแล้วก็ทำเรื่อง bereavement support
You all do a lot.
เอาละลาออกกันได้แล้วมันงานเยอะเกินไป
Now, there is another case that I would like to share, but apparently I'm being thrown out of the room.
yeah
Yeah. So I think that there is a case that is very interesting that I would like you all to just read. If I could summarize the case for you, we had a patient who had heart failure and lung failure, and she was dying. So we sent her back from the hospital because that is what she wanted, to die at home. But you know doctors, right? Sometimes the patients may not die in a short few days, right? They might take time. So this is what happened to the patient. She lived longer. She lived for 6 weeks. And her family couldn't cope. She became breathless. She was actually stable. Then she became breathless. Remember the common symptoms to be admitted back to the hospital? Pain and breathlessness. So if you want to keep your patient at home, address symptoms. They are the root of all evil. So they became breathless and she was readmitted back to the hospital and died in hospital, which is where she didn't want. And the family felt very, very sad about not honoring the wish. But we told them that it is not about where your mother dies. It's about the fact that she was comfortable when she died. It's about the fact that you were with her when she died. And this is most important to her. So you need to be a grief and bereavement support yourself. And you need to tell the truth, which is that your mother was comfortable and that you were with her all the way.
โอเคก็คงสุดท้ายเพราะว่าเดี๋ยวเราต้องคืนห้องนะก็คือคนไข้ตะกี้เนี่ยเขาก็เป็นทั้ง heart เป็นทั้ง respiratory failure ถูกส่งกลับบ้านคิดว่าจะเสียชีวิตเร็วปรากฏว่าอยู่ตั้ง6 สัปดาห์แล้วก็มี breathlessness ก็เลยทำให้อาจารย์เขาพูดต่อไปอีกนิดว่า2 อาการใหญ่ๆที่ทำให้คนไข้ต้องกลับมาโรงพยาบาลคือ pain กับ breathlessness เราจะส่งคนไข้ให้ดูแลที่บ้านต้องจัดการ2 อาการนี้อย่างดีถ้าทำได้ดีคนไข้มักไม่ต้องกลับมาอย่างไรก็ตามแต่เขากลับมาแล้วก็เสียชีวิตที่โรงพยาบาลใน3 วันหลังจากนั้นลูกสาวเสียใจมากว่าคุณแม่ไม่ได้ตอบสนองความต้องการของแม่ที่ต้องการเสียชีวิตที่บ้านอาจารย์เขาเลยบอกว่าเขาเลยต้องคุยกับลูกสาวว่าคุณอย่าไปคิดอย่างนั้นคุณต้องคิดว่าคุณต้องตอบตัวเองคุณต้องคิดว่าคุณแม่คุณตอนเสียชีวิตน่ะจากไปด้วยความไม่ทุกข์ทรมานใช่ไหมและคุณมีโอกาสอยู่ข้างท่านตลอดกระบวนการเสียชีวิตนั้นใช่ไหมถ้าใช่มันก็น่าจะมากเพียงพอแล้ว
So I think that the essence of palliative care in the home environment is that it is challenging. We do not have the facilities that the hospital have,
no.
and traveling from one patient to another is challenging. But we do it as a team. We do it knowing that we are part of a big team, and at the end of the day, it's not about us; it's about the patients.
การดูแลคนไข้ที่บ้านเป็นเรื่องท้าทายนะเพราะว่ามันยากลำบากแต่ของอาจารย์ด้วยระบบของเขาที่เป็นวงกลมตามฟลิปชาร์ตเนี่ยทำให้เขารู้สึกว่าเขามีหน่วยสนับสนุนของเราอาจจะต้องไปคิดดูนะว่าของเราจะทำยังไงได้บ้างที่จะเป็นระบบมากกว่าปัจจุบันก็แต่ที่สำคัญที่สุดต้องเอาประโยชน์คนไข้ตั้งค่ะโอเค
So I think that's the end of today.
Okay.
You've had a very long day. Tomorrow, what time do we start? 8:15, is it? Are you all okay to start 15 minutes earlier at 8:15?
พรุ่งนี้มา8:15โอไหม